So another complication with diabetes is hypoglycemia. And as you know, this is low blood glucose. This can be caused by too much insulin in proportion to the amount of glucose that's available. Blood glucose less than 70, although I know in our textbook it talks a little bit about that 74, 76 range. Normal defense for hypoglycemia is the body will have the counter-regulatory hormones released, such as the production of glucagon. The autonomic nervous system is activated, which causes epinephrine to be released. And that's what causes some of those other symptoms like shakiness, palpitation, nervousness, diaphoresis, anxiety, hunger, and pallor. As you know, the brain requires a constant supply of glucose in order for it to function properly. And when this doesn't happen, the symptoms can be similar to alcohol intoxication. The patient may have trouble speaking, visual disturbances, stupor, confusion, coma, and untreated hypoglycemia can lead to loss of consciousness, seizures, coma, and death. So hypoglycemia unawareness. This is when a person does not receive warning signs and symptoms of hypoglycemia until the glucose levels reach a critical point. They may become incoherent, combative, or lose consciousness. This can be related to autonomic neuropathy of diabetes that interferes with our counter-regulatory hormones. The risk is previous hypoglycemia episodes in patients who are prescribed beta blockers. So beta blockers really decrease a patient's ability to be able to know when they're hypoglycemia. So glucose goals might be a little higher for these patients. Another cause of hypoglycemia might be the mismatch of timing of oral intake to when the insulin dose is taken, or the oral hypoglycemic medication therapy, specifically like we had talked about glipizide, that actually causes the body to increase insulin production on our type 2 diabetes. Too much medication, so somebody took too much insulin, but it can occur with oral therapy or non-insulin injectables. And so these can be severe and persist longer due to the long duration of those medications. And of course, not getting enough calories or food in can cause hypoglycemia. So again, some of these are a little bit of a repeat. Other things that cause hypoglycemia: the delay in time of eating, unusual amounts of exercise. It can occur at any time, but most often when medication is in its peak action window. Disruption of a patient's daily routine without adequate adjustments. Maybe they didn't eat and they still took their medications. Symptoms of hypoglycemia can also occur if blood glucose is dropped too rapidly. And this causes a sudden metabolic shift. So example, somebody dropping from 300 to 180 may produce signs and symptoms of hypoglycemia, even though 180 is technically hyperglycemia to that person. They may feel like they are having hypoglycemia. So as you saw in SIM, hypoglycemia can be quickly reversed with effective treatment. So with the first sign of hypoglycemia, we want to check that blood glucose level as quickly as possible. If less than 700, if less than 70, we want to begin treatment. We want to investigate what could be causing it, maybe other signs and symptoms. If there's no blood glucose monitor, assume hypoglycemia and begin treatment and follow the rule of 15. So 15 grams of a simple carbohydrate, 4 to 6 ounces of fruit juice or regular soft drink. There are commercial products such as gels or tablets that it can be convenient for somebody to carry with them. We want to recheck the blood glucose 15 minutes later. If the glucose is still less than 70, we want to give another 15 grams more of carbohydrates and recheck the blood glucose 15 minutes later. If there's no significant improvement after 2 to 3 doses of 15 grams of simple carbohydrate, you need to contact the healthcare provider. There are some issues like shock, sepsis that can cause this to happen, so we definitely would need to let them know. So after an acute episode of hypoglycemia, you're going to have that patient take this complex carbohydrate to try to prevent repeat hypoglycemia. You're going to avoid treatments with carbohydrates with fats, such as candy bars, cookies, whole milk, ice creams, as fat slows the absorption of glucose and delays treatments. You also want to avoid over-treatment with large quantities of quick-acting carbohydrates so they don't get that large swing where they're hyperglycemic next. And always recheck the blood glucose in 1 hour or sooner if the symptoms reappear. In acute care settings, we may actually give that D50 if that patient is not alert enough to swallow. If they don't have IV access, then we're going to be looking at giving glucagon 1 milligram IM or subcutaneous. Remember, IM is going to be faster, and the glucagon stimulates a strong hepatic response to convert glycogen to glucose. Again, hopefully you remember from the sim, but glucagon, one of the big side effects of that is nausea is very common. So to prevent aspiration, we're going to turn the patient on their side or in that rescue position until they become more alert. If the patient does not have glycogen stores, they may not respond to the glucagon. And so individual patients with alcohol-related hepatic disease, starvation, or adrenal insufficiency may not respond to that appropriately. We want to teach family members how to use glucagon, and after somebody has hypoglycemia, we want to figure out why it happens so we can try to prevent it from happening again.